Hello and welcome to Healing Spaces, design dialogue for mental health, where we discuss the latest topics in behavioural and mental health design with industry experts and thought leaders. I am your host, Michelle Blackie, and I'm the head of strategic marketing at Pineapple, creators of mindfully designed furniture for challenging environments. I am so pleased to be joined by dedicated industry expert Elizabeth Johnson today to have a chat about behavioural health in rural and frontier systems. Elizabeth is an assistant professor, tenure track, at Mark and Robin Jones College of Nursing at Montana State University. She teaches design of healthcare delivery systems, which is an interprofessional graduate course offering with College of Nursing and College of Engineering students. There is even more information about what she has been up to on our podcast page on our website. But let's dive right in. Firstly, welcome, Elizabeth. I am so glad you managed to squeeze in some time out of your busy schedule to come and chat with me. But I think let's kick off with you giving our listeners a brief glimpse into your background.
Absolutely. It's wonderful to be here. I, first and foremost, am a nurse, and I started off my career in pediatrics. And beyond that, I started off in clinical trial care. So looking at novel therapeutics, novel treatments. And because of this was my first job in nursing, I had to make do with being agile, really giving a hug to the unknown, and having to work at that liminal space of what mental health looks like with patients, with families who were signing up for a treatment or therapy or device that may or may not benefit, that may or may not cure, that may or may not deburden their symptoms. And it really shaped my perspective. I spent a lot of my childhood on couches in my rural community. My mother worked with the Visiting Nurses Association, which is looking at home health. She was building the first hospice in our area, and I would tag along and would sit on those couches of different community members, help with Meals on Wheels, and found myself as I was managing these new therapeutics, aching to go back and provide service back to rural and sit back on those couches. And I feel like it'll frame a lot of the context for today.
So true. It sounds like it's managing a lot of unknowns, isn't it? All the time, coming at you from all different angles. But I think focusing on the rural aspect, can you paint the reality of a critical access hospital serving a 70-mile radius, for example? What does everything to everyone really mean in behavioral health?
To first provide context, because critical access hospitals can look so different where you practice and what their catchment is. Here in Montana, we're about the size of Germany in geographic landscape, but we are home to 1.1 million people. So very spread out, sometimes less than 6 people per square mile. We have 64 mountain ranges, 290 mountain passes.
And the people are spread out.
Yes, we're very spread out. And so for these critical access hospitals, they have to, as you said, be everything for everyone. So this requires agility in care service delivery. They can hold on to patients for about 96 hours. And so that means that there's significant likelihood for transition of care, change management, expectation setting, and are limited sometimes in how many emergency department bays they have, capacity for different specialties. You may wait hours to have a particular type of provider, if at all, be able to consult or to be able to be in person. So these are largely autonomous providers. who may see everything. There's also a high degree of familiarity in these critical access hospitals, as these are community members serving community members. So we have a lot to consider and account for with mental health as far as privacy, confidentiality, isolationism, if you are worried about seeking care because everybody knows you. Growing up, I remember my mom would be stopped in the grocery store all the time as people wanted to know desperately, how is this person doing? How is this going? And having to ride that fine line of concerned community members and confidentiality. And we still see that largely in rural spaces today.
It's funny how those vast spaces have such small communities, isn't it? It's quite ironic that you
Right.
live in these massive areas, but everyone knows everyone, where you come from, where you're going, what you're doing. But
Yes.
so specifically with behavioral health, which obviously is our area of interest here, in my line of work, I speak to a lot of experts in the sector, and I have been hearing a lot about the power of de-escalation first in behavioral health settings. So in your specific environments, how do you coach teams to create de-escalation first spaces when staff are stretched? They are anxious about safety. They're shaped by their emergency department workflows. I mean, what design features like layout, furniture would most reduce the escalation risk, especially when there's often no dedicated seclusion room, for example?
Yes. The first thing that we help coach with is to really know thyself. And this
Hmm.
can look different as far as environmental assessments as well as community health needs assessments. Many of the critical access hospitals and others like that designation that have a tax status have to do community health needs assessments. However, there's usually just the iceberg phenomenon. There's stuff underneath the surface that we must consider. For example, particularly in Montana, we have a much higher rate of binge drinking and substance use disorder. That care looks different, particularly with us, than maybe another area that doesn't have that highest of likelihood. We have a high veteran population here. We also have a critical suicide challenge with our youth as far as high risk. In fact, Montana youth are 2.7 times more likely to complete suicide than anywhere else in the United States. And we have a high rate of depression. 10,000 children per year in Montana are diagnosed with depression. And over 10% of our entire population have a mental health condition. So we have to, again, be everything for everyone, but how do you
Yeah.
create that type of adaptive space? One additional challenge I'd like to bring when we think about these is that many of our critical access hospitals are called Hill-Burton Act, or essentially those that were established during the act in the 1970s. So deferred maintenance, delays in adaptive renewal or restoration or renovation is very likely. So we have to make do, but also do with what we make. This requires usually these types of de escalation spaces to be very much closer, maybe to other focal points of care in the hospital than typically recommended because of the line of sight of the nurses, because that we may only have a nurse and a tech or a nurse practitioner, a nurse and a tech. This also has to mean that we're working with maybe built materials that are not advisable, or we have to start considering how safety and security is considered. So we have about 7 points of environmental assessment that we recommend, which includes things such as acoustic dampening. How are we looking at stimulation and de-escalation or destimulation in those rooms? And what types of technology integration are required to do so? What types of refortification are required? And how can we have better coordination of care with behavioral health hospitals, crisis facilities, and mobile care that's potentially available? It's altogether likely, particularly in Montana, that you may wait hours or days for a hospital, for a mental health bed. So how do we help manage that during those facility transfers?
Mm.
So again, being everything for everyone, We provide strong recommendations using eye tracking technology, using community informant interviews, using health assessment data, and using environmental data to provide a comprehensive picture of what that room should look like.
Sounds like you're always fighting off the perfect storm every day, just staying ahead of it. I mean, probably also since COVID, things have undoubtedly seen an escalation and it just needed a lot more attention than they previously had. But then conversely, also having received a lot more attention than they previously had, I would have assumed, same as the rest of the world, I think, in terms of focus on mental health.
It has, but hasn't at the same time. One of the things that stuck with me is I was with a community a couple years ago, and one of the community members came up to me after a meeting and said, make sure that they remember us, that we matter. And so I do feel that some have been left behind, either because of disparity in resource or grant funding,
Yeah.
or the cycle of pilot studies that maybe never took off, the lack of participatory co-design with the community to ensure sustainability of mental health initiatives and efforts. However, there have been wonderful programs and wonderful initiatives, especially here at Montana State University, that are nurse-led around opioid use, bringing into the fold other considerations for mental health of mothers who maybe have substance use disorder.
Yeah.
I'm energized every day that I hear of new creative and agile ways that nurses and communities are working from within to address their own challenges.
With creative solutions, I'll bet.
Mm.
So inside this type of community as well, I have another question for you for another angle, which is I want to touch on the necessity of addressing diverse needs in mental health design, which I think you also would face in these communities all day, every day. So how would you think these environments should reflect the Indigenous context and community governments? For example, local norms of care and dignity or tribal leadership. I remember you once mentioned as an example the significance of progressive leadership, so such as Indigenous female CEOs in fostering these inclusive environments, which sounds like a fantastic example of that, but maybe I'm just biased.
It's been one of the things I've championed and celebrated the most is to see Indigenous leadership hire Indigenous providers, provide that key information. Looking at, for example, one of the hospitals here in Montana has a smudging room. More are following suit. Being able to acknowledge cultural healing and practices. Many times, some of our tribal members say, when we're trying to box in mental
Mhm.
health, we're creating limited lists when really we're limitless beings. We are part of this larger universe. It's not that necessarily an illness. It's a challenge, it's a journey, it's a progression. And to acknowledge that in a healthcare system looks different. It's also understanding cultural implications and cultural assurances that this strongly spiritual undertone in belief can not only be acknowledged and accommodated, but celebrated as part of this. This sometimes looks at we may see more family members. We may see different prescribed healing herbs, indigenous medicines, or therapeutic sweat lodges. We may be seeing different chants, different songs that will be helpful. Um, but championing also in our hospital systems to celebrate that leadership has been incredible. And it's my hope that others will follow suit. And I know that we've seen in our allying states around us in our ecosystem that type of leadership, either through cultural navigation, cultural facilitation, or healthcare executives.
I love that idea of seeing it not as some horrendous illness that you're suffering from, but as a segment of a journey that you're on, a particular phase. I know some people might find that a bit dismissive of the pain and suffering they're going through. Someone says, "Oh, it's part of a journey that you're on," and they say, "But I'm in hell. I hate this." But I think some other people might find that quite comforting, where you think, the only constant is change. So this will not be the rest of your life. Things will change and things can improve. It's a very interesting way of looking at it. And I think I do think that the spiritual aspect of it and the spiritual approach to it can be very supportive in changing attitudes and perceptions of it to make it almost a bit of a softer landing, don't you think?
I think it's also helping us heal what has been largely stigmatized. That
Exactly.
you don't have to be identified by just this point in your life,
Yes,
and
forever.
it's forever.
Yeah.
And it's also allowing for that community support to emerge, which is a strong suit of rural and indigenous communities. I don't think I've ever been through a community where support has not just been lent. There's
Mm.
trust in that. That's where familiarity can be a wonderful double sided coin. But yes, it's something that we have to bridge and navigate for mental health, confidentiality, and privacy. But familiarity also means, as even things in my life, I've had community members who I didn't even know that they knew something had happened in my family. And I would see food on my doorstep or cards. And that familiarity also allows us to check in on one another. As third spaces deplete post pandemic, as our communities begin silvering or becoming
Yeah,
older, we're
yeah.
championing older in place, but that comes with dementia. It comes with sometimes cognition changes at the end of life. And it allows us as communities to check in on one another and be that swivel head in situational awareness that's not necessarily captured sometimes
Mm.
in large urban centers.
I feel like that is it's quite it's quite stark in today's society because it seems like society at the moment is on a trajectory of isolationism and which is fed by social media and everyone finding everything in their smartphone and the lack of community and community support which is then almost popping up in mental health illnesses and unwellnesses where you can see that these people, all they need is someone to check in on them. All they need is a friend. All they need is a voice or an ear. And it seems like there's a real unbalance at the moment of that. Not to hark back to the olden times where everything seems to be much better with rose tinted glasses, but like more people are getting old nowadays. So there's more dementia in communities. There's more cognitive issues with older people living longer, living independently. And community can be such a support in that. So, how do you find that working, firstly in the vast spaces, but also in the tight communities? I suppose you see the problem being solved, but also getting worse.
You're right. There is kind of a duality by which we see this. The more significant one I've seen currently is with our youth. I
Mm.
recall one meeting with a community where I came in to talk about one thing and we left completely focused on another just by their visual ask for permission to talk about suicide. The community members were wearing pictures on buttons on their shirts of the beautiful children that they lost.
That must be so hard because
It
people are so
is.
scared to talk about it.
And yet here they were. They were
Mm.
taking the initiative and the opportunity, knowing that they had experts coming into their community and saying, "Here we are, and we matter. And who's going to do something? We're here. Send us forward." At the same time, they had things that we were happy to celebrate, using the YMCA model, using after school programs, other different ways of checking in on one another. Having those key informants in communities such as home health nurses and public health who got to know a little bit about everyone. Our students, particularly here, there's certain diners or certain areas on the road stops where it's been great to observe how communities are working with another. How are they sharing resources? From carpools to making sure that people have warm meals. Who's going to the pharmacy today? There's this
Yeah.
interconnected highway of common thought on how to address. However, there are some unknowns that are almost intangible, such as technology, such as social media, and how to slay those dragons as it comes to adolescent behavioral health, for example, are going to be challenges that are much larger at the societal level, but the impact cuts deeper in
Yeah.
rural areas.
I did read an interesting, I can't remember what it was, an article or a post about, parents being so terrified of their teens on social media and getting lost. I think it's been with the spate of suicides as well, being encouraged by AI, for example. And it was a very refreshing approach by a child psychologist who said that, you know what, parents have always been terrified by what their teens are doing. In previous decades, it was comic books that were the great evil, or it was long hair, or it was all the things, or it was, nuclear war, et cetera, et cetera. There's always been something that frightens parents about keeping their teenagers safe. And she said the one thing that is consistent throughout is the relationship that parents have with a child. And the children, the way they interact with social media, it just amplifies how they are feeling. So if they enter the relationship with social media feeling depressed, threatened, sad, upset, it will amplify that. But if they feel confident within themselves, they have good relationships in their lives, that will get amplified. They will seek what they need in social media because of their real environment, the real community that they're living in, the tangible 3D life that they are living. And I thought that was a very interesting way of looking at it. Instead of laying all the blame at social media, it is still real life that is driving how we feel. It might be amplified by social media, it might be supported by social media in good and bad ways, but it's the real life support and the structure and the loving relationships that still count.
And that's where I feel that rural areas are leading in
Yes.
how to create healing environments, particularly post pandemic. There's nothing that warms my heart more when I pass a T-ball league. There's nothing that warms my heart more than seeing little ones playing soccer out in the back field, or even with my two young sons begging to go meet friends in the neighborhood at the park. But having them outside and celebrating environment as part of health was one of the elements I feel like we gained back
Yes.
post-pandemic rather quickly, because it's part of our spiritual makeup and fabric
Mm.
that we share, and something that we celebrate as part of where we live. Community members have shared with me that creating walking paths, for example, having mobility and exercise equipment outside,
Yes.
ways to organically meet people, organically create these clusters of families, of cohorts together. That sure, that many restaurants or other, elk lodges may be closing, but where can we create organic community and facilitate and enable what we know to be a strength? And that's something that I hold and carry through with a lot of what we're trying to do with research, what we're trying to do with implementation science, is leverage the strengths and things that we already celebrate and we find good and we have joy in. And can that lead forward? And as you note, can that dilute or drown
Yeah,
out the negative things that are highly socially engineered and
exactly.
out of our control,
Mm.
largely in those technological spaces?
No, absolutely. And I know that probably is another podcast topic that we need to earmark. So before this one gets too long, I need to ask you one final question.
Of course.
And that is, if a rural CEO has one capital project this year, what, in your opinion, would be the highest return on investment change for behavioral health outcomes?
I would say multi-use community space.
Mm,
We had one health system that said it best, where they said, the community only sees us as a place to go when you're sick.
yeah,
So to even cross our threshold is a reconciliation. I'm sick. I'm not well. And is that fair?
yeah,
Personally, no. And so we've started seeing this take back of what would be considered non-revenue generating space, such as atriums, alcoves, maybe um, unused space
mm,
between different care environments. Can we add co-working space? Can you add a gym where maybe your community doesn't have one? Can you add community kitchens?
yeah,
Can you add, like one of our communities can you have a lunch cafe open in an assisted living so that the assisted living residents can commingle with the community
exactly.
over food? This is the way forward. And I am assured of it when I start seeing what we could even do with a gym. We can add prehabilitation. We can add exercise and movement as medicine.
Exactly. Prevention is better than cure.
Exactly. Co-working, have youth be able to stay in their communities? Can we work on entrepreneurship and innovation and aligning that to our healthcare systems? I don't see anything higher in ROI than giving the community space, not only to heal, but to seeing a healing space as part of their future.
Yeah, I agree. I love that. That's a great positive note to end on. But Elizabeth, thank you so much. That was fascinating. And you and I both know that we'll be meeting on the podcast again to discuss many of the other topics that we can talk about. But thank you so much for joining me today. And to our listeners, obviously, stay tuned for the next podcast as well. And we'll see you soon. Thank you.